This is the Royal Adelaide Intensive Care Unit's intubation guide for the coronavirus pandemic. Being prepared, using the checklist, knowing your roles, and clearly communicating with closed-loop communication where instruction is given and repeated back are key. Prior to entering the room, you need to assemble a team, ensure you have the correct equipment, and have discussed the plan for intubation. Your team should consist of an airway doctor, who should be the most senior intubator available, a team leader who is responsible for giving drugs and providing circulatory support, an airway assistant, an in-room runner, and someone outside the room who can pass things if needed and scribe. Additional staff may be used outside the room as additional runners and for checking correct PPE practices. Your equipment should be prepared using the checklist and checked by the whole team prior to entering the room. To preserve equipment, please take note of what is already available in the room, and there are a few things to consider when preparing your equipment. The bag valve mask assembly should include a PEEP valve and a HME filter. It may additionally involve a capnograph. The ventilator assembly should include a HME filter, inline suctioning, and a separate capnograph. Video laryngoscopy is strongly recommended to improve first pass success and to allow the operator to increase the distance from the airway. So taking a CMAC with the blade of your choice should be your first line. Backup and rescue equipment should be prepared on the trolley outside the room to be pushed in if required, or placed in a double bag so that it will not need to be destroyed or left in the room. When preparing drugs, it is important to use high-dose neuromuscular agents to ensure a good block and to protect against coughing. You should also bring a vasopressor into the room. It's important to plan the intubation and ensure the whole team understands that plan. In particular, make sure everyone understands what to do if one airway approach doesn't work and when you'll try another technique. It's also important to have a plan of when and how to deal with critical hypoxia. It is worth considering how to make the out-of-room activity as succinct as possible, but this step is vitally important and must be treated with the utmost importance. It might be worth practicing this step in a sim environment if you get the opportunity. Once you are satisfied with your team, equipment and plan, you take off lanyards, stethoscopes, empty your pockets and don PPE to enter the room. The intubator should wear a full face shield. You should bring a disposable checklist into the room with you. Connect the ventilator assembly if this is possible and calibrate the capnography. Set the ventilator to your desired settings and check all monitoring and IV access. Place a Yankee sucker under the pillow and optimize the patient's position. When pre-oxygenating, it's important to use a two-hand technique with a vice-like grip to reduce aerosolization. This is why it's worth considering having end-tidal capnography in the circuit. Induce the patient and wait a full minute for muscle relaxation to take effect. This will reduce the chances of a cough and subsequent aerosolization. Provide apneic oxygenation using a PEEP valve on a bag valve mask assembly. High-flow nasal specs will increase the risk of aerosolization. Unless you have critical hypoxia, don't provide bag ventilation, again, due to the risk of aerosolization. Intubate the patient using video laryngoscopy. Don't get a direct view. You may wipe the bougie as it is removed and disposed of to reduce the risk of it flicking respiratory secretions. It is important to use closed-loop communication if you use a bougie. By placing a second capnography adapter in the ventilator assembly, you just have to move the sensor from the bag valve mask assembly to complete the setup during intubation. The cuff must be inflated before any ventilation is provided. Again, ensuring closed-loop communication is vital. Commence ventilation and check end-tidal CO2 and chest rise and fall. If you fail to intubate the patient, provide rescue breaths via an eye gel, and if unsuccessful, go back to bag valve mask ventilation. This should be declared as a can't intubate, can't oxygenate scenario, and front of neck access prepared. If front of neck access is required, this should utilize a scalpel, bougie, tube technique, and any ventilatory effort should be ceased prior to the first incision to reduce the risk of aerosolization. If critical hypoxia is observed following induction and prior to intubation, bag valve mask ventilation should be provided. This must be provided in a two-person, two-hand technique to minimize aerosolization. Following intubation, it is appropriate to connect the patient back onto the bag valve mask assembly and hand ventilate the patient initially. However, should you do this, it is vitally important the tube is clamped prior to the change from the bag valve mask assembly to the circuit. The tube should be secured in place, and any equipment that needs sterilisation should be bagged in the room and double bagged when leaving the room. Ensure all equipment is cleaned prior to removal and PPE is doffed with the utmost care. The key take-home messages are to plan and prepare before you enter the room, to use the recommended PPE, to have a HME filter in your bag valve mask assembly and in your circuit, to pre-oxygenate with a two-hand vice-like grip, to use high-dose neuromuscular blockade, not to provide bag valve mask ventilation during apnea unless the patient becomes critically hypoxemic, use video laryngoscopy if able, and don't commence ventilation until after the cuff is inflated.